you, and good morning, everyone. We've heard such riveting and interesting dialogue around the specificity and the granularity of the issue, thinking about rural disparities and how those disparities are characterized through oral health. What I want to help us do this morning is to actually zoom out a little bit and to think about how marginalized populations, meaning what the factors are that contribute to the inequities that then are evidenced in disparities. Because I think it is necessary for us to also have that level of a viewpoint in addition to the granularity of the conversation today. I am, as mentioned, the Chief Strategic Integration and Health Equity Officer at University Hospital here in North New Jersey, where my office focuses on population health, community health, as well as community affairs, the human experience, equity and inclusion, and strategic planning. So this is a lot of the work and the lens of the work that I do on a daily basis. Next slide, please. So let's start here. It is impossible for us to have a conversation, a dialogue, a meeting of the minds and hearts, if you will, about the topic of disparities without rightfully placing them in a larger context. So often I have a conversation with people about the difference between equality and equity. And we can't assume or take for granted that everyone understands the nuance between those two terms and what is necessary as interventions or actions to achieve equality versus achieving equity. I came across this graphic at least a year or more or so, and I've used it every time I've had a talk because I just think it is so profound and so digestible for the audience. So here you see Addressing Imbalance by Tony Ruth, originally appeared in the Design in Tech report in 2019. Shows you a tree that is skewed in one direction, shows you two individuals on either side of that tree. In addition to noticing that this tree is skewed in one direction, you notice that the fruit proliferates on one side of the tree. If any of you are familiar with the public health pantheon of Dr. Kimara Jones, then you will know that this is also congruent with her gardener's tale that talks about it is not just the outcome of disparities, but it's what's in the soil that predisposes the disparities that we are seeing, meaning what are the inequities driving those outcomes. So back to the tree. Equality says, give them both a ladder. If you give them both a ladder, hey, both will have access to fruit. But it does not negate the fact that the tree is skewed and leaning in one direction, and that one side of the tree therefore has less fruit. Again, this causes me to think about the definition of racism, a definition that has been popularized by Dr. Jones, a system of structuring opportunity whereby one group is advantaged based on skin color or phenotype, which is a social construct, whereby another group is advantaged based on skin color or phenotype, which is a social construct of race, but the strength of a society as a whole is sapped. So I want you thinking about that definition as we're looking at this tree. And I'm spending some time here because if you walk away with anything from my talk, walk away with this. Equity says, I'm not going to give them equivalent trees. I'm going to give equivalent ladders. I'm going to design a ladder that achieves the goal, meaning higher ladder so that the person on the right can access the fruit. But that does not change the fact that the tree is leaning, it's skewed. Systems are designed to produce certain outcomes. Unless there is intentional disruption of those systems, the inequities will remain and the disparities will continue to proliferate. Hence the topic, health justice in marginalized populations. Next slide. So if we think about the rural-urban disparity, I want to focus there because I've done a lot of conversations during this pandemic around disparities related to COVID, and in particular disparities in how they appear in different geographic, racial, and ethnic groups across the United States. And a fine line for us to really begin to understand is the difference and the similarities, I should say as well, But here the difference is in rural and urban populations around mortality, because what we know that the challenges that are faced by rural communities have implications for the entire country. Because whenever a population is historically excluded, historically stigmatized, or marginalized, be it by systems of oppression, be it by less economic development or access, those factors can be specific to those populations, but oftentimes those factors are similar across multiple populations. Next slide. And in particular, looking at this graphic that was pulled from this publication by Cross et al., looking at that rural-urban disparity, we actually can look at age-adjusted mortality trends. And we look at those trends from 1999 to 2019. What are the big picture things that we take away from this graphic? Okay, we see that, yes, there has been an improvement in age-adjusted mortality for metropolitan areas, for small and medium-sized metropolitan areas, and for rural areas. But I think the more compelling thing to note here is that the actual disparity between large metropolitan areas and rural areas has grown. It has grown across 1999 to 2019. And not only has it grown, we see that rural communities continue to suffer disproportionately or experience disproportionate rates of age-adjusted mortality. We know that within those populations, that African Americans or Blacks have the worst mortality rates across all three groups. But we also know that in particular, non-Hispanic white adults in the certain age range, so thinking about 25 to 64, have actually seen an increase in their mortality. And we've experienced that in rural communities as well. Next slide. So what are the inequities in rural America, and what are those implications specific that we can learn about for oral health? 1 in 5 Americans live in a rural community. My family comes from rural communities, my mother being from Clarksville, Virginia, right on the border across the state line from Oxford, North Carolina, and my father and his family coming from the Richmond area, and prior to that, the Portsmouth area, also in Virginia. So 1 in 5 Americans live in a rural community, but fewer than 10% of physicians practice there. We oftentimes talk about access and access to care, but let's think about access specifically to primary care, preventive care, and then oral health care. And then let's also think about how access to care impacts health-seeking behaviors, impacts whether or not persons feel validated by the available care that is there to them, because then that influences access to care. Another statistic, 24% of rural Americans are people of color, and that's largely driven by growth in the Latino population. We know that we see higher levels of diversity in our urban areas, but that is a compelling number to note. We know that rural Americans have higher risk of premature death because of the following conditions. You can advance again. And we know that these inequities are driven largely by rural Americans being slightly older in age, poorer in health, and having higher rates of tobacco use. We just heard about the social cultural dynamics around big tobacco, having come from a family that farmed tobacco, very well aware of that, and farmed tobacco for generations. High blood pressure and obesity. Advance once again. And finally, rural residents have higher rates of poverty. And what are the implications of concentrated poverty? We talk a lot about concentrated poverty, meaning generations of successive economic disinvestment, being locked out of economic opportunity, and being locked out of economic opportunity, how that, those political determinants of health, those structural determinants of health, those social determinants of health drive health outcomes and are the same factors that are implicated in oral health disparities. Next slide. So place matters. This is what I want us to get down to, the very nuts and bolts of the conversation. Place matters. In public health, I am a public health and preventive medicine physician by training. We talk often around how place determines access. Place determines the distribution of resources. And it's not just the structural definition of place, but it is the political context of place. It's the social and cultural context of place. It is the policy context of place, as well as the environmental context of place that determines the distribution of resources that shapes and characterizes systems of oppression and systems of imbalance. And I think it's very key to focus on the CDC Social Vulnerability Index, because there are congruencies between the Social Vulnerability Index that portend the disparities that we see in rural communities and even specific to oral health. So the Social Vulnerability Index, as you see written out here, can be grouped in 4 major categories: factors that look at socioeconomic status, factors that look at household composition and disability, factors that look at minority status and language, factors that look at housing type and transportation. I can tell you a lot of conversation during the pandemic that began to refine why it is that we see a disproportionate and devastation in Black and Brown communities is because of where they live. It's because of where they work. It's because of the use of public transportation. It's because of burden of chronic disease. And a lot of those same factors are determined by socioeconomic status, household composition and disability, historically excluded groups in language, and housing type and transportation. Next slide. And if we just take that place conversation to the next level, you now see a new term being articulated: geospatial determinants of health, so that people realize when we talk about an environment, we have to talk about an environment on multiple levels. And why is talking about the environment important? It is one thing to talk about the environment, to be able to characterize disparities. And a fair amount of our conversation goes there. But in an asset-formed approach to public health and population health, we want to be able to characterize assets also in those environments, because whenever a community is able to exercise self-governance, whenever a community is able to exercise self-autonomy, when a community is able to say these are the resources and assets that within systems can collaborate with community to then plug deficits. So knowing those environments is important. The natural environment, right? Access to green spaces, built environment, roads, okay? Housing, things of that nature. Population connectivity. We see a lot in rural communities, isolation, right? We saw isolation, unfortunately, grow exponentially during the pandemic, but rural communities have been geographically isolated. And being geographically isolated, what are the impacts of that isolation? So that is what is meant by population connectivity environment. You can also think about that from a technological standpoint: access to telehealth, access to broadband. How do you cultivate digital literacy, digital natives versus digital immigrants? These are all topics of conversation in public health. And finally, social and behavioral environment and our health policy environment. There is a place for understanding at all of those successive levels, because our action must be multi-layered. Our action must be at all of these different rungs in the ladder in order to dramatically change systems, in order to dismantle, disrupt, and undo inequities, to erase disparities. Next slide. And finally, I'll leave us here, leveraging solutions in a health justice framework. So when you hear me or another person say justice, I want you to go back to that graphic that we started with. That tree is skewed. Just putting a ladder there is not going to help. That tree not only is skewed, it has more fruit on one side because of the root. The access has caused that side to be richer. Just putting ladders of different heights there will not help. We got to make the tree upright. So in making the tree upright, we must understand the persistent, recent, and emergent challenges facing rural communities. And this was from a report done in 2019. These challenges have been exacerbated by the pandemic, and is why we are seeing the oral health disparities that we are discussing today. And it's why we saw the changes in the age-adjusted mortality rates with that widening gulf or gap between rural and large metropolitan communities. And the stat that I pulled out around white Americans of a certain age, and especially in those rural communities, that are actually having an increase in mortality though the trend line is decreasing overall. So we see persistent, low patient volume, smaller community sizes. We see a payer mix that is oftentimes skewed toward the Medicaid and Medicare population. Think about reimbursements. So there is a place for a policy conversation here. We cannot be absent those policy conversations. Think about patient mix. Think about the stats that I quoted around rural persons being slightly older, sicker, and the disproportionate burden of disease that they are faced with. And again, that geographic isolation. And then the flip side of that, we also need to think about those access issues, workforce shortage. We know workforce shortage has been exacerbated during this pandemic. Those who usually have a compelling mandate and purpose to practice in excluded group environments in communities are those who have ties to those communities. Thinking about the use of community health workers, thinking about cultivating pipelines of talent to care for communities. Just calling out another one, being very sensitive to time, thinking about regulatory burdens and coverage. And we do know that in communities where there has been a Medicaid expansion, we have seen upside benefits. And in knowing that that has directly someone needs to directly contributed to upside benefits, that goes back to that policy environment that I talked about before. So this is not a one-sided solution. This is not a one-size-fits-all solution. This is a multi-layered, complex, robust, comprehensive, muscular, granular solution that looks at the physical environment, that looks at the built environment, that looks at the policy environment, the people connectivity environment, and the social behavioral environment. So I thank you for the opportunity to discuss this morning, and hopefully we've given ourselves all something to think about more deeply.